Hello, we are live on Facebook. I'm James Hamblin. I'm a lecturer at YSPH, and I am joining you for the fourth installment of COVID-19 right now, where I talk to various guests about what is at the front of their mind at the moment. This is a live stream, so you can drop questions that you might have about anything at all, but ideally things that are relevant to what we're talking about right there in the comments, and we will take them as best we can. I am joined today by Pam Sutton-Wallace. She is a YSPH alum and Senior Vice President and Regional Chief Operating Officer at New York Presbyterian. Pardon me. Thank you for joining, Pam.
Thank you, James, for having me. Really excited to be with you today.
So I like to start always with this. Just what is at the front of your mind right now in terms of you are mobilizing the workforce, trying to keep everybody healthy, both inside the hospital and outside. So you have a big job right now.
Indeed.
What's the biggest challenge that's, kind of keeping you awake at night?
Oh, wow. That's a big question. I think it's really precisely what you said, that as many people have said, this is unprecedented for the United States. And I think the challenge of keeping our workforce energized, equipped, informed, being transparent about the crisis that we're enduring, and really trying to give them all the information and the tools that they need to do their jobs well and to sustain over such a long period of time, right? Most of us, particularly here in the New York area, have managed a crisis that lasts, 1 or 2 days or maybe a week at a time, but to go months in this kind of mode of having to stay hypervigilant, alert, keeping yourself abreast of as much information as possible while delivering outstanding care and good service to our patients. It's a monumental task. Add on that many, many logistical challenges, ranging from everything, thinking about food sources for your family, childcare, transportation, all the way to, do I have the appropriate PPE to take care of a COVID positive patient? It's a lofty task.
So everything is keeping you awake at night, it sounds like.
Yeah,
Could we start with the PPE, because that's been in the news a lot. How are you feeling right now in terms of supplies for all your healthcare workers and how they're being effectively used? The PPE.
Yes, PPE has received a lot of attention, and appropriately so. I think, we received our first patient on March 8th, and literally a month later, you have thousands of patients. And most of our healthcare systems aren't able to ramp up that quickly to secure and procure supplies, including PPE. Fortunately, we had internal stockpiles that we were able to utilize until we were able to receive very generous shipments from the state to support our activities. And it was touch and go there. We've heard about the kind of infamous now N95s. And really that's kind of a hallmark piece of equipment that is used by our professionals, especially those most closely and directly touching patients.
Right.
So there was, times where we were very concerned about running out, but at this time we're in a good position. We feel we've been able to provide our staff with all forms of PPE that they've needed to support their practice.
Okay. So in the short term, at least, you're good. Do you know about longer term, like supply chains that are being shored up or anything for the state?
There is, and I think things got particularly precarious when China closed, when of course China was undergoing their own strains on PPE. And for a while there, they weren't manufacturing either because of their shutdown. And that's where we've really felt the intensity. Since then, China has started manufacturing more product, and are now manufacturing internally. The challenge now has been the distribution channels, which have been shut down due to policies that are put in place to really protect citizens, but are causing other kind of global supply chain issues.
Right.
And because China and Asian countries manufacture so much of our supply sources, while we're feeling better, it certainly can change at any time. And I think that's the fear factor, that at any moment things can shift pretty dramatically. Now,
Right.
Fortunately, we're finally starting to see a little bit of a plateauing of admissions, and that's helping us quite a bit. But we want to be prepared.
Right. Which brings us to the really hot button question right now, at least in the political realm, is this claims of reopening the country in a very near term. To what degree do you see potential for, beginning to decrease shutdowns and social distancing, and in what term would you feel comfortable, just purely from your own hospital's capacities perspective, feel like you think maybe we could let up a little bit on the social distancing?
Yeah, of course, we're in the epicenter, right, of the activity in the United States, and it's been a frightening time. And as I said, for the first time in the last week, we have experienced fewer admissions than we have over the prior 3-week period. Now, that being said, we are still experiencing admissions, so they haven't stopped. We also have found that 25% of our hospitalizations require an ICU admission. And quite frankly, that's what's putting the most pressure on our systems. Those ICU patients are generally staying in the ICU for more than 20 days. That's an extraordinary amount of time in the ICU. And that's a lot.
Yeah. Wait, 25% of COVID-19 admissions are are going to the ICU.
Correct.
And a majority of those are staying longer than 20 days.
Correct.
Okay. Sorry.
The average length, I should say that, no, you're spot on. The average length of stay of that patient right now is about 20 days. It's dropping a little, but in general, that's an extraordinary long period of time. Yeah. And so that means we haven't yet fully experienced all of that length of service that's required for patients who are still coming in. And to me, that says we're not ready to shut down or discontinue our social distancing policies, our masking policies in public, our visitation policies, because this disease, we just don't know enough about it. We don't know, testing wasn't ubiquitous. We don't know how many people really have been exposed. We're not quite clear on when people are most symptomatic and when they are most likely to transmit the disease to others. And as long as we have that lack of clarity, in my mind, we're not ready to discontinue those policies that have really helped us to flatten the curve, as it's been said, in the hospital setting, to reasonably be able to treat the number of patients for the length of time that we're talking about. Right. In many places, people who have stopped the social distancing have actually seen minor spikes back up in their healthcare settings. And we're not prepared for another spike. It takes its toll on people, equipment, supplies, families. So I would say in a place like New York, New Jersey, Connecticut, we're not there yet. Right. Maybe another
So reason. The answer be kind of indefinitely, we should, at least for the short term, we'll reassess later, but we should not talk about letting up anything right now.
It wouldn't be my recommendation or my preference.
Oh, yeah. No, I purely from the perspective of you, the healthcare workers you're charged with protecting. Obviously, I know you're not in charge of the finances of the world either, but that is really helpful to hear. I mean, I think people are experiencing kind of different worlds right now. Everybody's living at home and looking outside and seeing a quiet, sunny day. And it's hard to remember that there are people spending 20 days in your ICUs and that your medical staff, is working like they've never worked before, probably in their lives. And there's that tension between people need to be reminded that their efforts are important and that the risk is still, this is a serious disease out there, and we can't, if we
That's
let up,
right.
you're going to be putting people in danger. Yeah.
What we know is it's very much in the community. And the last thing we want to do is make our healthcare workers at greater risk when they are home or when they're outside of the hospital to create community acquisitions. We already know our employees have gotten sick, not necessarily in the hospital setting, and that puts further tension on the healthcare system as well.
Right. How about ICU capacities? If you most places I've talked to have created sort of makeshift ICUs or COVID specific ICUs. Can you talk anything about like design and triage patterns that have been effective for you that might be effective for other people? We've got, the YSPH community watching, so I think everybody's trying to share the lessons that have been helpful to them in trying to figure out how to adjust for this new disease.
Yeah, it's a great question. At baseline, New York Presbyterian had 421 ICU spaces available. We now have actively 900 ICUs available and can surge up to 1,200. That was our plan, to be able to get to 1,200 ICU bed spaces. You can imagine tripling your ICU capacity requires you to use every nook and cranny of your hospitals to create beds. So we have literally converted our ORs, our PACUs to ICU spaces. We are using tents, both outside of our emergency department, to create triage stations for those who may be concerned that they have mild symptoms and want to be tested or are afraid, the worried well, some of us call that group. We've created within our hospitals and in lobby spaces, what we're calling kind of internal field hospitals, where we have brought in pods, anywhere from 23 to 50 pods located in lobbies, and our cafeteria has been remade into bed spaces so that we can decant our acute care beds and create more ICU beds. Really innovative strategies. I can't believe the efforts, really heroic efforts of our facilities teams, our IT teams, who have literally stood up ICUs where there were, lunch tables in the past, and that's required bringing in O2 systems. Everything we've done incredibly creatively. We've turned one of our Columbia University's athletic fields into an internal field hospital that has capacity to care for 200 patients. Out of the generosity of the military, they're helping us to staff that facility as well. But it really has been an extraordinary effort to use every viable space to surge up.
How are we defining ICU beds in a situation like this? Does that mean a ventilator, or does it mean a certain level of constant monitoring and nursing support, or how do you get to that threshold of qualifying as an ICU bed?
It's all of those things. It's
okay.
A tighter ratio of nursing staff time available to you. It's having technology more readily available. The monitoring. So for almost all of our ICU spaces, there are ventilators required. Most of the patients are also on a vent. Mm-hmm. And so it really requires all three of those things. And typically they're cared for by an intensivist, someone who is specially trained in critical care medicine, to be more observant, to monitor airways and the like. And because this disease impacts the lungs, constant monitoring and vigilance of both respiratory concerns as well as cardiac concerns become really important.
This might be premature, but there's some talk in academic circles of exactly what the right point to ventilate a person is. And there have been some cases where people have been using CPAP and BiPAP to really good effect at oxygen levels that we didn't think traditionally in other diseases, you would need to be intubated. And actually people were doing fine, if not potentially even better, without early intubation. Has any of that reached into clinical practice to the point that it's changing any of your calculi about how, potential ventilator shortages, or is that still too preliminary?
No, it's absolutely a viable alternative. We have identified where all of our BiPAP and CPAP machines are, should we need to deploy those for ventilation purposes. We have resisted using that until we absolutely need it. We've been fortunate enough to be able to keep up with the demand using not just ventilators, but using anesthesia machines as another form of ventilation. And that has been able to, the two of those have been able to allow us to meet the needs of our ICU patients. That being said, we did rely again on receiving stockpiles from the state to help support us.
Yeah. So we've heard a lot also about, elective procedures being canceled. As some things are truly elective, but it's a malleable term, right? It kind of just means maybe it could be pushed a little bit, but not indefinitely. We're not doing things purely just for fun. What's at the front of your mind in terms of what will be the top priorities to get people in to do as soon as we can start rescheduling some of those things? Because we can't get them all scheduled on the first day back. What's at your mind in terms of we need to really get on this, right? As soon as possible.
Yes, it's a great question. You asked me what keeps me up at night. This is probably the second topic that keeps me up at night. As you can imagine, there's going to be a lot of pent-up demand of things that we haven't been able to do over the last month, including what you correctly term as elective surgeries. Now, we have proceeded with urgent and emergent surgeries, but those things that are semi-urgent or what are deemed elective, we're going to have to make really hard decisions about how do we re-enter that process of scheduling OR cases and procedures. Fortunately, there's been guidelines put out by a lot of the surgical professions to help kind of categorize cases. And we're going to bring those to bear, working together with our surgical colleagues to really outline how do we start making those hard decisions. We're also beginning the conversations of how quickly do we ramp up? Maybe we have to do surgeries 7 days a week as opposed to 5 or 6. Maybe we have to run our ORs longer during the ramp back up period. Yeah. But these are really important conversations that we're having now, what we're calling our restart phase of when we're finally able to start sunsetting some of those surged areas of capacity. How do we quickly then bring up and restore our prior capacity, but also being very thoughtful about how do we use some of the things we've learned to redesign some of our processes, perhaps that are outdated. So it's an important time, and we're thinking about those very topics now. Sure.
How about the personnel issues? Where are you feeling most like if we really do have to continue, say we're not seeing the levels of immunity that we were hoping for, and we continue to sort of flatten the curve, but it continues to be high case rates for a while. What part of your personnel issues are the kind of most in need in terms of volunteers or extra support? Is it nursing, respiratory therapy, ICU physicians?
It's all of those. I would say particularly nursing, respiratory therapist, all the disciplines, pharmacy technicians, our environmental services staff were heavily hit by community acquisition, our supply chain teams. I think what it's important to remember is these folks have been working, 12 to 16 hour days, 6 to 7 days a week. We're trying to give people time off to rest, of course. We're thankful for many outside hospitals and health systems who have come and are volunteering or bringing their services here. For example, UCSF has sent a number of volunteers who are now practicing.
Oh, wow.
Yeah, it's been great. Cleveland Clinic is sending teams of folks. I referenced the military has stepped in and is providing respite for some of our folks. So it's been a wonderful to watch this kind of healthcare brotherhood take place. But it also will require still, there's some things that only, our teams know and understand. And so we've got to be mindful of that transition. And again, another reason not to yet lift the social distancing or physical distancing and to enhance testing so that we can flatten that curve to give people some breaks.
Right. Yeah, and if things start to pick up in places like San Francisco and Cleveland, that's going to be bad for you and places that are relying on extra workforce volunteers, right?
That's right.
There was a question about state licensure of people practicing and coming to volunteer in moments like this, that theoretically, you should be able to go anywhere and help out. Are we still, people are only practicing in New York if they're licensed to practice medicine in New York, or has that been suspended?
That was relaxed. So
that was relaxed.
That was relaxed by the state, and thankfully, so
yeah.
that we were able to take advantage of these volunteers who are willing to come and help and support us. We are required to capture, obviously, some of the basic information and for credentialing purposes, but we can now practice across state lines.
That's one of the many changes that I'm following in terms of, it might be hard to go back from some things, including the increasing use of telemedicine. And it seems like there'll be some longer term changes where this is giving us a proof of concept that, it's not like practicing law where there's a bar you have to pass in every state. The medical licensing exams are, not state to state. It's just a licensing process at state to state. Are there other ways in which you're seeing that you've actually found efficiencies or found things that you think longer term could change the way you operate?
Yeah, I think you raised an excellent point about the licensing and credentialing. You also mentioned telehealth and telemedicine. So prior to the COVID experience, we were about 2% of our clinic visits were telemedicine. Telehealth, we're now at 35%,
wow.
If not more. That's the last time I checked. It's probably closer to 40% now. I don't think we'll ever go back to the same type of in-person bricks and mortar visits in the way that we were prior to COVID. In some ways it's ideal, in some ways it's not ideal, but it certainly proves that we have better ways to do clinical visits, remote patient monitoring. How do we monitor people at home, getting them discharged earlier so that they really could be in a home space with their families, but yet can still be monitored. I think, this is going to be a new world order. I think we're going to be living with COVID for a long time to come. It's still unknown whether there will be seasonal resurgence of COVID. Some are speculating that we can see this again next winter, but because of that long tail that I talked about in terms of care, we're going to have to make sure that we redesign our waiting spaces and how close people sit next to one another. We've got to think about, how do the things that we touch, having PPE available to staff all the time, especially if we don't have yet ubiquitous testing and tracing and isolation. We have to basically assume that everyone is COVID positive. So I think some other interesting things that have changed is many of our corporate services or administrative functions have also assumed not direct patient facing, but supported our caregivers in different ways. For example, some of our IT staff, some of our analytics teams have helped to build out some of our facilities, or they're helping with transport services. Interestingly, they've been able to think about redesigning some of our systems and processes based on their experiences now hands-on. And that's been enlightening, right? To think about how can we redesign, lean out some of our processes for the future with people who have insights into that kind of work.
Yeah, it's unfortunate that this has to be the circumstances under which we're discovering them, but these emergencies force us to find efficiencies and determine what's really necessary and what can be, done more efficiently. I have notes here from viewers. If anybody else is watching and wants to get a question in, we can take one or two. But we have John here from YSPH 01 who's working helping the COVID-19 response in Athens. And he says he appreciates the update, and we appreciate your work, John. And we also have a question here. Can you discuss displays by other first responders that have been happening outside hospitals, like the clapping that's happening every night at 7 o'clock? And do they help with morale? What else can non-healthcare workers do to show support?
I can't begin to tell you how important moments like that are. I get teary just thinking about the 7 p.m. claps. Our healthcare professionals stop and listen and wait for it. It's those moments of encouragement that changes everything. I think simple things like thank you notes. We have people who post signs, wait for them to leave their shift, and they have thank you signs, of course, staying 6 feet away, but just showing gratitude. People have, many organizations have provided meals and discounts, have offered to do shopping for healthcare workers who don't have time to do shopping themselves, have offered childcare services in their homes so that they can come to work comfortably. I think just moments of gratitude to the whole range of healthcare workers, not just our nurses and doctors who are on the front line, but all those other disciplines who really help undergird the entire system.
Great. Well, I think we can wrap up there. And I really appreciate your thoughts. And I want to kind of recap for anyone who's kind of tuned in late, though, that the main message here is that people are working really, really hard, like they never have before. And the social distancing is extremely effective. And from your perspective, as someone whose job is to keep people inside and outside the hospital as well as possible, there's not in the immediate term any good reason to think we should be relaxing anything right now, but that we should continue as we have been and reassess later on down the line. And,
I think that
does that sound correct?
it does. Look, I'm like most of it. I hate being stuck inside.
Oh, no one likes it. No, yeah.
But this is the right thing to do for not just our healthcare workers, but for our community at large. And, I think in the long run, we will come out for the better of it, making the hard decision now than to later not be able to care for patients the way we all want to be cared for.
To double down on that, I think it makes this point, and I wanted to ask, there's some people who believe that there's sort of a public health ignorance of financial issues, that people are advocating social distancing because they don't understand that there are economic effects to it. But I would assume that your hospitals are experiencing economic effects of this. This is not something that you are welcoming to have to cancel all of your elective procedures, which are surely sources of revenue. And can you? I mean, could you maybe close with any indication that could help alleviate concerns that this is just that we're operating without
consideration,
mindfulness of everyone's the financial straits that social distancing puts everyone in?
Yeah, I mean, without a doubt, it puts a further strain on our healthcare system. Unfortunately, I think we're all keeping track of the unemployment rates. If you look at, they're skyrocketing and have skyrocketed. When people are unemployed, they generally also don't have healthcare insurance. And we fully expect a longer term issue of more uninsured citizens who are going to continue to need care. And that's going to put further pressure on an already tenuous healthcare financial system. In addition, not only is there, lost revenue from the elective surgeries, the magnitude of increase in expense associated with providing this level of care for so long, and supplies now cost more. A challenging supply chain distribution system means that you have to find innovative ways to get things to you. A lot of hiring of couriers and support teams. So it's an enormous financial drain on an already precarious American healthcare system. In fact, I worry tremendously that we will see hospitals who don't have the financial capacity to weather this close. And, it's a third thing that keeps me up at night, right? That our healthcare system that's already on shaky legs will find itself further on shaky legs. But that being said, in times like this, it's people first and it's care first. And I think we're hard pressed to make a decision that is solely based on economic, on systems. If it was my mother, your mother, we wouldn't want that for them. And so I think we have to think with a broader approach. Again, I think the time will come where we have to make hard decisions about weighing the balance. I think for the purposes of a city like New York, given the density, given the reliance on public transportation, we're not there yet.
Yeah, I know MTA rides down, on the subway, they're down like 93% or something. So, and even the MTA is taking huge financial hits, but I mean, that means barely anyone's riding it. And if we were to open up even, halfway, that would just put a massive strain on a system, on the people in your healthcare system.
I think until we know, and I've heard you speak before about testing, until we have good testing, reliable testing available, until we can trace and isolate people appropriately based on those tests, we're not ready. We've got to be able to respond to hotspots if someone is infected and to stop and treat. We don't even have effective mechanisms to treat patients yet. So, or to prevent it. That's become really critical when we're making the decisions to open.
Pam, thank you so much for joining us. Always good to have an alum. You're the first alum we've had on the show.
Really?
Well, I guess sort of. Alum is current faculty, but it's great to hear, and thank you for all your work on the front lines. And I know you got a lot of work to get back to, so we'll close it there. But thank you. Hope you get some sleep after I've talked about all the things that are keeping you up at night.
I'll do my best. I'm grateful. Thank you.
Okay. Take care. Bye.